Thank you, Dr. Fink, for that introduction. And I'm really excited about sharing the work we've been doing, and excited to hear kind of some of the questions at the end, and hopefully it builds on future collaborations. This is my conflict of interest. And then so for the overview of the talk, first we're going to be talking about the heterogeneity in the acute kidney injury clinical syndrome and how this heterogeneity may limit the identification of potential therapeutics. Then talk about a methodology we've been using called latent class analysis and how we're able to use it to identify distinct sub-phenotypes of acute kidney injury. Next, talk about the divergent clinical outcomes as well as response to treatment based on these sub-phenotypes. And then finally, looking at genomic discoveries that we've been able to do looking at these subgroups. And then finally, talking about some of the future directions, and then also as well as some of the advantages and limitations to this area of work. All right, to start, I think it'd be helpful just to define some key terms. When we think about sub-phenotype, or another term that people have heard about is endotype, it's often a subgroup within a larger clinical syndrome, and we'll be talking more about that as the talk goes on. Prognostic enrichment is the idea of a certain indicator variable to help you inform clinical risk. An example that we use commonly in the ICU is thinking about lactate. And then predictive enrichment, in contrast, is an indicator that helps you define potentially which patients may respond differently to a certain therapeutic. And I think in the asthma literature we've seen a lot of examples of this, especially looking at peripheral eosinophilia. And then the final concept is heterogeneity in treatment effect. And so this idea that differences in treatment response in a group is due to variability in drug response within the group. And so to talk a little bit more about this idea of heterogeneity in treatment effect. And so here on the left here is, I just want to see if this, okay, there's a figure in the top left here. So on the x-axis is a certain patient characteristic, and so on the y-axis is the treatment effect. And each dot in this figure is an individual patient in a clinical trial. And as you can see, the overall response in this clinical trial, there is no treatment benefit with the therapeutic being tested. And if you look across different patient characteristics, there's a pretty consistent effect. In contrast, if we have this figure where overall, again, the overall treatment benefit, there's no treatment benefit in this clinical trial. But if you look at patients with the lower severity of illness as well as the higher severity of illness, they potentially may have been even harmed with the therapeutic. But then there's this subgroup of patients that may have had a benefit. And so another way to show this is when we have this heterogeneous population of patients, potentially within that there are subgroups that are more biologically similar, and potentially these subgroups respond differently to therapeutics. This is a nice quote from Francis Collins, the director of the NIH. He was saying, drug development in the US is in crisis. While we know the molecular and genetic basis of 5,000 plus human diseases, we have safe and effective treatments for a fraction. 90% of drugs that enter clinical trials will fail, and the estimated cost of a new drug approval is greater than $2 billion US. And one of the reasons for these issues may be this heterogeneity in treatment effect. So there's been a lot of interest in this concept of precision medicine. I mean, I would, though, argue that medicine's always attempted to be precise. And as clinicians, we've always tried to identify discrete subgroups that may benefit differently to a therapeutic. There's many examples of this, of different metabolism of medications based on gender, as well as potentially different therapeutics based on background. And so another example I think that we commonly think about sub-phenotyping is looking at patients with heart failure. So now commonly we differentiate patients with heart failure with preserved ejection fraction as well as heart failure with reduced ejection fraction. However, this is a relatively somewhat new concept and is really in the early 2000s when there is a consensus statement that said we should start defining patients with heart failure with preserved ejection fraction. And then there's been multiple clinical trials that have found therapeutics that work in patients with reduced ejection fraction are not effective in patients with preserved EF. And then there's been follow-up proteomics analyses and others looking at that the underlying biology may be very different between these two subpopulations. So if we've been doing this for a long period, then so what's different? And I think one of the main points that's been different is how much data we now have, and especially looking at all the omics approaches that we have available, from genomics to transcriptomics to proteomics. And really the big challenge now is how can we incorporate that data to identify underlying patient populations. And this is one example from the asthma literature, but I think it highlights some of these concepts. And so in this study that was published in 2009, Prescott, Woodruff, and other investigators from UCSF, they looked at epithelial cells from nasal brushings, or airway epithelial cells in patients with asthma. And they looked at 3 specific genes for gene expression. These were IL-13 inducible genes. They found that they could identify 2 clusters of patients based on gene expression of these 3 genes. So a Th2 high expression cluster here in the red, and then a Th2 low expression cluster here in the blue. When they followed up with that, they looked at data from a clinical trial that randomized patients to inhaled corticosteroids or placebo. And in this figure on the y-axis is the forced expiratory vital capacity, or FEV1. And so if you see in this trial, when you stratify patients based on Th2 high or Th2 low, there's a very different response to inhaled corticosteroids. And in contrast, when you look at patients in placebo, there's really no benefit, of course, with corticosteroids. So potentially this is arguing that there's a subpopulation in asthma that may have even a harm giving inhaled corticosteroids. And so now switching gears and thinking about acute kidney injury. So some of the background, so acute kidney injury is an acute reduction in kidney function that often we see in the hospitalized setting. It's one of the most common forms of organ failure and critical illness, and one of the most common risk factors is sepsis. Currently, AKI is defined by a rise in serum creatinine or a drop in urine output. And here, this is the consensus guidelines, but you can see that each subsequent stage of AKI is based on how high the creatinine rises. One of the things to highlight here is a patient just needs a 0.3 milligram per deciliter increase in creatinine to have AKI. So it's a very sensitive definition, but it may not be that specific. And so AKI is quite common. There's some estimates are almost a third of all patients in the ICU have some form of acute kidney injury. And it has clinical consequences. So when we're caring for patients in the ICU, we're concerned about electrolyte imbalances. And there's a challenge with dosing antibiotics as well as other sedatives and analgesics. And then there's issues of edema, either pulmonary edema or kidney edema. And then there's biologic consequences from coagulopathy, immunity, and organ crosstalk. There's a heterogeneous cause for AKI, so everything from sepsis to contrast to trauma, and then the pathophysiology is quite diverse, from cellular injury to inflammation or even fibrosis. And despite all this, though, we don't have any proven pharmacologic agents for the prevention or treatment of AKI. And I think one of the reasons for this is this issue of heterogeneity. So this is not an exhaustive list by any means, but it's a list of therapeutics that have been studied in acute kidney injury. So everything from insulin-like growth factor to low-dose dopamine to atrial natriuretic peptide to even different resuscitation strategies. One of the main takeaways is all these trials, even though they had strong preclinical evidence and early phase clinical trial data to be supportive, they found no mortality benefit in the larger clinical trials. And I think one of the reasons for that is this heterogeneity and even the phenotype, which you can see the first trial looked at patients with acute tubular necrosis, so a subtype of AKI, while other trials looked at patients on dialysis. And then the last trial in this list looked at patients who had septic shock, who are at risk for AKI. And then, so last time when I was working in the ICU, this is the set of patients that we took care of who had acute kidney injury. Everything from an elderly person with tumor lysis syndrome, a young woman with pancreatitis, and then another patient with staphylococcus bacteremia and endocarditis. And then what we're seeing more commonly is a patient with COVID pneumonia with severe acute kidney injury. And so I think this again highlights that there's a very diverse clinical phenotype underlying AKI, but how can we potentially split patients to understand an underlying biology? And so the fundamental problem is that combining this heterogeneous clinical AKI population may limit the identification of therapeutics. And so one thing that we've been doing as a group has been using this methodology called latent class analysis. It's a type of statistical analysis that's based on mixture modeling and based on the hypothesis that there are distinct subgroups of patients within a larger population. The goal of LCA is to identify subgroups that are similar based on observed or known characteristics. And LCA asks the question whether the data distribution is better in a 2-class model versus 1 compared to a 3-class model versus 2, and so on. And one of the points to highlight is that unlike regression analyses, this type of approach can be independent of clinical outcomes. For example, you can use baseline clinical data that was collected prior to randomization in a clinical trial to identify these subgroups. And here on the right, we have a figure where we look at the distribution in a potential clinical trial, and you can see that there may be 2 hidden or latent subgroups within that overall trial. And this interest in latent class analysis has really picked up recently in the medical literature. So papers have been recently published looking at this in sepsis, as well as acute respiratory distress syndrome and other syndromes in the ICU. And so I'll be specifically talking about looking at it with acute kidney injury. So then what did we do? So we looked at 2 cohorts of patients. These are all patients had acute kidney injury and were admitted to the ICU. The discovery population was a prospective cohort of ICU patients we enrolled at Harborview Medical Center. It was almost 800 patients, and then the validation population included patients enrolled mostly external to the University of Washington, so Massachusetts General Hospital, UCSF, as well as Penn. All patients had EDTA plasma collected within 48 hours of ICU admission, and LCA was run independently in both populations. And we used 29 different input variables, clinical variables, as well as research biomarkers that we measured. And this is just to highlight that the kidney is a very vascular organ, and one of the underlying pathophysiology is thinking of endothelial dysfunction. And so we really tried to focus on markers of endothelial injury when we're identifying these subgroups. And so the variables we included were common demographics, as well as comorbidities such as chronic kidney disease, as well as others. ICU level factors, such as if they are mechanically ventilated on vasopressors, and then clinical variables, so common laboratory variables we get in the lab. And then we also looked at 2 sets of research biomarkers. So these were markers of endothelial dysfunction, Angiopoietins 1 and 2, and vascular adhesion molecule, and then research biomarkers of inflammation, interleukin 6 and 8, as well as tumor necrosis factor and the FAST receptor. All measurements were done here at the University of Washington using a mesoscale discovery platform. And Gerald Herting from the Department of Sociology was provided support on this. So what do we find? So when we first applied it to the discovery population, we were able to identify that LCA identified it a 2-class model that better separated the data. And here you can see around 60% of patients fell into class 1 and 40% into class 2. And then when we, here now we looked at stratifying all the variables and developing a heat map. How do these variables separate between the 2 classes? And so we termed them AKI sub-phenotype 1 and AKI sub-phenotype 2. And as you can see, the markers that most differentiated the 2 groups were the ratio of angiopoietins 2/1, as well as TNFR1. The next thing we did was trying to understand, are these 2 subphenotypes specific to AKI, or could they be groupings that are in general critical illness? And so looking at a patient population without acute kidney injury who are also enrolled in that same cohort in the ICU at Harborview Medical Center, we found that we were unable to identify subgroups within the larger population, potentially suggesting that these are AKI-specific subphenotypes. We then looked at the validation population. And so again, applying LCA, we found a similar distribution of the patients where a two subgroup model best discriminated the data. And then when we look again at the variables, many of these change their rank order, with platelets and sodium bicarbonate being more important in this modeling. But then when we see at the top, the ones that best separated the two populations, again, were angiopoietins and TNFR1. So then the next question we had was, now that we've identified these two subphenotypes, can they better help us understand the risk of clinical outcomes? So this idea of prognostic enrichment that I talked about before. And so what we first looked at was hospital mortality. And so on the y-axis is the percentage in hospital mortality, and then we have the two populations, the discovery cohort and the validation. In the white bar is mortality overall in all the AKI populations. And as you can see, when you stratify them based on subphenotype 1 and 2, there's almost a 2 to 3 times higher risk of death in subphenotype 2. This is after adjusting for severity of illness based on Apache, as well as their KDIGO stage of AKI, so their traditional classification of AKI. The next thing we wanted to look at was, how can we move this to the where a clinician could potentially measure or identify these patients at the bedside? And I think one of the big challenges is a clinician can do latent class analysis on one patient, and it's going to be challenging to do 30 different variables. And so this is work with Leila Zelnick from the Kidney Research Institute, but she was able to apply a machine learning model called lasso regression to identify a parsimonious set of variables that could potentially differentiate these two subphenotypes. And so we split the discovery population into a training and internal test group, and then we had an external population. And so we found that this 3 biomarker profile, angiopoietin 2/1 as well as TNFR1, had quite good area under the curve, or C statistics, in the discovery population. While the C statistic was attenuated in the validation, it still performed well enough where we were hoping to move this further into another cohort. Briefly, I just want to talk about the biology of angiopoietins. So here's a cartoon of an endothelial cell. So the Tie2 receptor is a cell surface phosphorylated tyrosine kinase receptor. There's 2 real natural ligands for it, angiopoietin 1 as well as angiopoietin 2. Ang1 is released by parasites as well as platelets, and oftentimes during states of health, it's quite elevated, binds to the Tie2 receptor, and leads to endothelial stability. In times of inflammation, such as sepsis or trauma, there's release of Ang2 from preformed granules. There's also increased Ang2 gene expression. It binds to the Tie2 receptor and leads to activation, where it leads to endothelial apoptosis, death, and the clinical syndrome of capillary leak and edema. What's particularly exciting about this Ang-Tie2 pathway is there's been a number of preclinical studies looking at modulating this pathway to improve outcomes, especially kidney-specific outcomes. So there's been studies looking at agonists for Ang1, antagonists for Ang2, as well as agonists for the Tie2 receptor. And recently, there's, to my knowledge, these are the first 2 trials, clinical trials, where they're looking at, in COVID specifically, an agonist for Tie2, and then there's an Ang2 therapeutic that's being studied in COVID also. I don't know the results of those studies, but it looks like these therapeutics are moving into the clinical setting. So then, we're not the only group looking at AKI subphenotypes. This is data from the Finn AKI group, so it's the Finland group that was also looking in their ICU patients with sepsis. They're trying to identify similarly AKI subphenotypes. So they had 301 patients. They used 30 different variables, and some of those overlapped with ones that we looked at, so including angiopoietin 2, lactate, as well as creatinine. But many of these were different, including metalloproteinases and other circulating biomarkers. And interestingly, they also found a 2 subphenotype model best differentiated the patient population. But I think one thing to highlight from this is that no one variable seemed to predict class assignment. And so arguing that potentially there could be a few different ways to identify these two subphenotypes. So then this next part is what I've been excited about. So then the question is, now that we have identified these two AKI subphenotypes, do they potentially respond differently to therapeutics? And one of the things particularly we've been excited about in the ICU is treating patients with septic shock, so treating with vasopressor therapy. And we have quite a few options when we're caring for patients. And so there's been preclinical data as well as early phase clinical trial data suggesting that vasopressin is associated with improved creatinine clearance and increased urine output in patients with septic shock. And the hypothesis is that vasopressin may preferentially vasoconstrict the efferent arterial, while in contrast norepinephrine may vasoconstrict the afferent as well as the efferent arterial. And so that's why vasopressin may be beneficial in this population. There was a large randomized controlled trial that was published in 2008 called the Vasopressin versus Norepinephrine study in septic shock. I'll talk a little bit more about that, but that's the VASST trial, and that overall was a negative trial. Afterwards, they did a follow-up analysis where they looked at stratifying patients with AKI or no AKI. And they found that in the AKI population, potentially there was a lower risk of mortality. So this then informed another large randomized control trial that looked again at this same combination, stratifying or randomizing one patient group to norepinephrine versus another one to norepinephrine plus vasopressin. The big difference in this second trial was looking specifically at kidney failure-free days. And unfortunately, they again found a negative study, so they found no difference in their primary outcome. But in their secondary outcome, there was this vasopressin may be associated with less need for dialysis. This was published in JAMA in 2017. And so what we did was we went back and worked with investigators who worked on the VASST study. So just to remind everyone, so VASST was, it included 800 patients enrolled from 20 sites. All patients had septic shock and were already on 5 micrograms of norepinephrine. They then were randomized to 2 arms, either continuing norepinephrine or the early addition of vasopressin. And here's a Kaplan-Meier curve where you can see that 90-day mortality, there is no significant difference. So working with collaborators at UBC, we worked with Jim Russell as well as Keith Wally, we were able to get access to blood samples that were collected on these patients prior to enrollment in the clinical trial. And so from those blood samples, there are 326 that were randomly chosen, and of those, 271 patients had acute kidney injury prior to enrollment in the study. And so applying the 3 biomarker model that Leela was able to develop, we were able to test this in this cohort. And so approximately 150 patients had subphenotype 2 and 113 had subphenotype 1. And so here's our main results looking at a forest plot. And so in the first column we have the primary outcome we looked at was 90-day mortality. And then the second column are patients with norepinephrine. And then the third one are patients who were randomized to norepinephrine plus vasopressin. And so as you can see, in all patients with acute kidney injury, there is no significant difference between getting vasopressin or norepinephrine. And that's consistent with the larger clinical trial. In contrast, when we stratify patients based on subphenotype 1 or 2, we find that in patients with subphenotype 1 have almost a 46% reduction in mortality. In contrast, patients with subphenotype 2 have no difference in mortality. And then the p-value for interaction was 0.05. And this was even after adjusting for severity of illness. So this was highlighting that when we combine all these patients together and look at them in a clinical trial, potentially we're hiding this signal that we could identify when we identify these subgroups of patients. We also looked at 28-day mortality as well as kidney-specific outcomes, so dialysis and 7-day renal recovery. And in all these, we found that subphenotype 1 had an improved outcome with vasopressin therapy. So then I just want to talk about a little bit about the next steps we were doing with this work. So one of the areas was identifying, using these subphenotypes to identify underlying genetic risk. And this I want to talk quickly because kind of running low on time here, but we did a mediation analysis, so using single nucleotide polymorphisms as an instrumental variable looking for outcomes. And there's been examples of this being done with LDL cholesterol. And so what we specifically did was, in the validation population, we had genome-wide data. And so while it's a small group of patients, only 425, we said, can we do a targeted analysis based on these 3 genes that transcribe these proteins that we found that are important in identifying these subgroups. So the Ang1 gene, the Ang2, and TNFR1. And so we found no variants that were associated with subphenotype 2 in Ang1 and TNFR1. But interestingly, in the Ang2 gene, there was an intronic variant that was associated with lower risk of developing subphenotype 2. The same variant was also associated with lower plasma Ang2 concentrations, and the effect mediated by Ang2 was almost 42%, suggesting that if we wanted to move these AKI subphenotypes to the therapeutic setting, potentially modulating the Ang2 pathway may lead to some benefit. And then we did some in vitro assays looking at, these are human microvascular endothelial cells, and finding that patients with the T allele, the minor allele, had lower concentrations when we cultured these HMX and measured Ang2 concentrations. And then the next part I just want to talk about, this is future work that we're doing, but we're working with the CLOVERS randomized control trial. And so this is a trial that's ongoing. It's enrolled 1,400 patients, and it's randomizing patients with septic shock to early vasopressor therapy or continued IV crystalloid therapy and then late vasopressors. And our hypothesis is that patients with AKI subphenotype 2, so more endothelial injury, may benefit from early vasopressor strategy. And so we have approval to work on the blood samples that were collected prior to randomization for this trial. And hopefully down the road I can share with you some of the results of this. And then the last part I wanted to talk about was, how can we move this to the clinical setting? And so this is something that I've been excited about. So this grant was written almost 2 years ago before COVID started, and we were going to look at sepsis specifically. And then since COVID started, we pivoted to COVID, but we have an ongoing prospective cohort where we're enrolling patients with COVID-19 or suspicion, or without COVID-19 but admitted to the ICU with suspicion. And so we have, and the plan with this is we're collecting plasma EDTA samples as well as citrated plasma samples. And we've been working with Roche Diagnostics on their instrument to develop some of these research biomarkers. And so currently in our lab, it often takes 6 to 8 hours to measure these biomarkers, but with this instrument from Roche, it's potentially up to only 20 minutes for each measurement. And so hopefully this allows us to maybe move some of this work into the clinical setting. And then just finally, I wanted to highlight some of the advantages and limitations. So one of the challenges is it's hard to get clinicians to narrow use of a drug. And so I think we've seen many studies finding that there's a subgroup of asthmatics that benefit from systemic corticosteroids, but oftentimes those are still given to patients. And so I think that's always going to be a challenge when we're identifying these subgroups. I think the other challenge is there may be biologic pathways that overlap different syndromes. And so the subphenotypes we've been identifying in AKI have some overlap with work that's being done in sepsis. And I don't think that's necessarily a problem. And so, there's been a lot of work looking at peripheral eosinophilia as a predictive biomarker in asthma, especially for use of mepolizumab. And now there's even recent work looking in another airway disease such as COPD and using this therapeutic. And so I think a lot of these pathways probably overlap across diseases. And then the final thing is, I think it's always important to know the data that someone's working with when they're identifying these subgroups. And so looking back at some of the data from the FIN-AKI study, they found plasma creatinine really didn't separate these two subphenotypes. And one observation could be maybe creatinine is not important in identifying different subgroups of AKI. But another potential observation could be that there's not that much variance in creatinine measurements because everyone enrolled had acute kidney injury. And then the final concept is this idea of this balance between public health potentially versus precision medicine. And so these were two studies that came out in the New England Journal on the same issue. And I think it highlights this, this challenge, but I think the other thing it shows is that ideally we're able to give therapeutics that work for a broad base of the population, but as hopefully I've shown, in AKI that hasn't been working. And so I think in certain diseases we have to split the patients to identify subgroups that may be more biologically similar. And so the advantages of a clustering methodology, we can identify these disease subgroups. They potentially may respond differently to clinical treatments. And then these techniques are incorporating other omics approaches and getting more advanced as we go. And so the take-home points, AKI is a heterogeneous clinical syndrome, and heterogeneity may be obscuring our attempts to find effective pharmacotherapies. Using LCA, we've identified 2 AKI subphenotypes with different genetics, clinical and molecular profiles. And then many of these concepts are additive from other fields, and the best approach to identifying AKI subphenotypes likely depends on the treatment being studied. There's a lot of people I want to thank, especially my mentors Mark Werfel and Jonathan Himmelfarb. And then I'll just end on this slide.
Well, that was great. I'm going to get us started while people can submit questions through the Q&A. I mean, I think that this is just really opens up so many questions about how does this apply in so many other situations, right? Like, and then sort of thinking about, like you said, AKI and sepsis, for example, right? There's sort of a Venn diagram of overlap there. And then how does that overlap with COVID? So I wonder if you can kind of elaborate a little bit more on, you know, what your hypothesis might be around COVID, and whether you think that sort of different therapeutic approaches might be something that we should think about, kind of given the underlying pathophysiology.
Yeah, no, that's a great question, and I think you know, we've been doing some work with this, and hopefully we have a paper that's going to get accepted soon, looking at specifically endothelial dysfunction in COVID. But I think one of the things we looked at with that is there's been all this interest in vascular injury and thrombosis in COVID. But when we looked specifically at our patients and did some of these different biomarker assays, we found that endothelial dysfunction really wasn't that much higher in COVID, and in contrast may have been much lower than we see in bacterial sepsis or other causes of sepsis in the ICU. And I think that's consistent with some of the prior literature. When we think of viral sepsis, it's very different than a bacterial etiology. And so there's, like I was mentioning to you, there's through the I-SPY consortium, there was a trial looking at an agonist for Tie2. All I know is that that trial ended early, and either that can mean that the drug worked very well in COVID, or it potentially was not effective. And so we have to see what they find. But I think from our local data, we're finding that endothelial injury is not really a hallmark of COVID sepsis.
So we have a question from the audience. The patient populations in the studies that you talked about today were very sick, hospitalized patients. Do you have any insights about AKI as it might be encountered in outpatient settings?
Yeah, no, that's a great question. I would have to punt to this, partly because I'm a pulmonary and critical care doc. I've been mostly working with ICU populations. One of the other challenges with outpatient AKI is it's very much a very different clinical phenotype. Medications are often the most common risk factor, and so some of these findings likely and probably are not translatable to that population of patients.
Do you think that there's a role for trying to do similar types of work in those types of populations? And what would you expect you might find?
Yeah, no, I think that would be great to work in that area. I know some people here who've been working on that. It's especially challenging just to identify these patients and start developing kind of those clinical questions. People specifically have been looking at medication-induced AKI. Classically, the thought is with medication-induced AKI, it's more of an apoptosis type epithelial cell injury in the kidneys, and so maybe it'll be a very different pathophysiology than what we're thinking about sepsis and so on.
We have a question from a hematopathologist who's wondering about von Willebrand factor and the role for that in the setting of AKI.
No, that's a great question. And we've been working with some hematologists locally, as well as there's a pediatric nephrologist who's been interested in that too. Ang Lee was working here but now moved to Texas, but he was interested specifically in looking at this syndrome of MAHA in post-bone marrow transplant patients who develop acute kidney injury and thinking about this microvessel thrombosis. And so we haven't done that much work looking at coagulation. One of the pieces is with COVID, because that's so interesting, we've been doing more studies with von Willebrand factor and others. And so I don't have a lot of data to show about that, but I think that's something we're trying to investigate more.
My own interests in inflammasome pathways and how those might contribute to inflammation make me wonder about tissue factor also. I don't know if that's something you've ever looked at.
No, and maybe offline we can talk more about it, because I think, you know, I mean, that's what's great about talking to lab medicine about the options of what we can potentially assay. We haven't done that yet.
Mark Wenner says, in the Finnish study, CRP seemed to distinguish the subtypes. What other inflammatory markers have you looked at?
Yeah, we've mainly looked at clinical inflammatory markers, kind of like Mark was mentioning about CRP. But then the research ones we measured are mostly interleukins, soluble TNF-R1 receptor, TNF-alpha, the soluble FAST receptor, which is probably more apoptotic. And then in our COVID studies, those are the main ones. We've measured others in our COVID studies, but it hasn't really panned out to have that much of a difference.
So it's been, you might have to repeat this, Susan, so that I have not like. So for when you find genetic differences, it's really difficult to go from a research study looking at genetic differences to operationalizing, clinically trying to use those genetic differences in any way. Have you thought about how to operationalize genetic, the testing genetics to be able to figure out how to use that?
Yeah.
You have to repeat my question.
Yeah, Dr. Schertz was asking, translating genetic differences in a research setting to the clinical sphere, especially when you're caring for potentially critically ill patients that have a very dynamic illness. You probably are a better expert at this than I am. You know, that's been one thing we've been thinking a lot about, especially since some of these clinical trials are collecting DNA as well as RNA. And so thinking about potentially pharmacogenomics and with therapeutics, I don't have a great answer for that. The main ways we've been incorporating genetic analyses into our studies is using it as a way to understand the underlying biology of the disease. And so when I was showing you the instrumental variable analysis, so can we potentially maybe go to a drug company and say we have great preclinical data, clinical data, and then we also have genetic data supporting this as a potential causal pathway that we should modulate? That's mainly what we've been looking at.